Thank you, the organizers of Avatar, for giving me this opportunity to be back home. Central veins, and we've been focusing on catheters all morning. Unfortunately, all of these catheters end up in the central vein. And the outcomes of long-term morbidity because of those catheters is borne by the patients where stenosis of those central veins will cause dysfunction of any future AVF. So the focus that I would try and do today is emphasize that the dialysis circuit actually starts and ends at the heart. And that's an important concept that we need to realize, that the blood flow comes out of the left ventricle through the aorta, down the draining arteries, and the fistula could be in any part of those distal draining arteries, and then the blood then has to go back all the way back to the right atrium. And if there is any occlusion in that circuit anywhere, it will cause the pressures in that draining circuit to go up, and those increased pressures will cause a decreased flow in that axis, high pressures, venous hypertension, arm swelling, thrombus formation around the area where there is stenosis, as well as possible decrease in access flows. And all of those are going to be detrimental in patients' ability to get adequate dialysis. So here again, this is a patient who had central vein stenosis right in the upper draining part, and because of that, the access flows were low. So it's important to realize that the dialysis circuit is a complete curve, it's a full circle, and the dysfunction could be anywhere. When the dysfunction is in the central vein, as I alluded, those would be the consequences, and all of those will prevent you from attaining good dialysis clearance or ability to cannulate. Sometimes this edema is so severe that you're unable to even palpate the fistula and not able to cannulate those veins. Or the venous pressures become so high that the moment you take those needles out, there is extensive bleeding after the needles are removed. A patient with arm swelling should not be ignored, and at the earliest we need to try and get an angiogram, because the ultrasound duplex in this patient is not going to be helpful in evaluating the central venous system. So you will need an angiogram to look for any central vein stenosis. The number 2 point that I would try and emphasize today is that central veins are highly prone to be stenosed. And our CKD patients are exposed to a lot more morbidity and hospitalizations than your non-CKD patients for a variety of reasons. They're coming in with volume overload, they're coming in with infections, they're coming in with other complications, and frequently they're getting central vein access across different vessels. And we've talked about the benefits and the risk of having central vein catheters in these 3 different locations. And they are used for different indications in different locations, and different surgeons or radiologists would prefer one site versus the other. But it's important to realize that it doesn't matter where those catheters go. As soon as the catheter is in, especially in those internal jugular and the subclavian veins, they will interfere with venous circulation eventually. And the risk of thrombosis is as high as 30%. The problem is there are no good studies that have looked at prospectively as to what is the risk of thrombosis in these patients. Biofilm or fibrin sheath has been discussed a lot over the last 2 days now. And I would say that the fibrin sheath is actually a misnomer. It's more of a biofilm. The moment you puncture the vein, there is a thrombus that forms at the site of puncture of that vessel. That induces inflammation, and as that inflammation and the thrombus propagates, and if there is a foreign body around it, the biofilm will try and encompass that foreign body and prevent it from causing any harm to the body. So it starts as a thrombus and then kind of propagates all along that catheter, and that process is starting within minutes of the catheter insertion. So why do some people continue to have a catheter and yet the catheter keeps functioning for several years? whereas in other patients, the fibrin sheath develops and disrupts the catheter flow within days, is unclear. But the biofilm is fairly active. It has active cells and inflammatory components, and slowly smooth muscle propagates into it, and that's what gives you that thick fibrotic fibrin sheath that develops over time. PICC lines, I'm not sure how often do we use PICC lines in India, but in the United States, PICC lines have become a huge problem in CKD patients or even in regular patients. Patients come to the hospital for any acute infections or long-term infections, and you put in a central venous line through the cephalic vein or the basilic vein. There are PICC teams in the hospital that are running around putting these PICC lines in patients so that they can get IV antibiotics. Patients, as they continue to get more and more of those, the IV access becomes more challenging, and the residents are frequently calling on the PICC team to try and get that access. The risk of thrombosis could be as high as 30% after you've had a PICC line, and PICC line damage is even more extensive now because not only there is a risk of central vein thrombosis, but also thrombosis of those distal peripheral veins that we would have used for placing that access. The third point I want to make today is that the outcomes of central vein interventions are not stellar. We have struggled to come up with the best way to manage central vein stenosis. There are three options at our hand. We can either do primary angioplasty with stenting with a bare metal stent, or primary angioplasty and stenting with a covered stent. When you look at the older studies, which were primary angioplasty alone, you look at the 6-month patency rates, primary patency rates, and the 12-month primary patency rates. Only 1 in 10 or 1 in 2 of these patients will have the central vein patent after a year. The average rate of repeated angioplasty, in my experience, has been about 2 or 3 procedures in a year per patient if you're only doing primary angioplasty. And there is a risk, and there was a study done which clearly showed that every angioplasty may actually increase the risk of restenosis in those patients, because angioplasty itself is causing some degree of inflammation and injury to that central vessel wall, and prone to a higher risk of thrombosis after that. And then there is a thought that some of those central veins are elastic while others are not. And one of the studies that looked at it clearly showed that if the central vessel wall was elastic, and you really have to wait at least 5 minutes after you've done the angioplasty. So right after the angioplasty, you may get a good stellar result, and the stenosis is less than 30% now. But if you wait about 5 minutes and repeat an angiogram, right on the table you would see some of those lesions to be recoiling and elastic. And when you follow those patients will almost certainly have a recurrence of symptoms, and perhaps there is a role of primary stenting in those patients. Whereas the other lesions which are not elastic usually tend to have better outcomes with primary patency. So perhaps there is a difference in these lesions. So KDOKI has looked at the indications for stent placement, and they do recognize that there is an acute recoil, and those patients should be considered for a primary stent placement at the time of PTA. But certainly if you have a patient who's had a recurrent lesion after the first angioplasty, we need to try and put a covered stent or stent in that patient. So once you decide that you have to put a stent, you have options. You have those stainless steel stents. We have those Nitinol stents, which are newer. They are more flexible. They tend to conform to the body's anatomy a lot better. And then there are PTFE covered Nitinol stents. So the older data, if you look at the stainless steel or the Nitinol bare metal stents, and these are the stents which are not covered, they do not have any PTFE layer on it, the primary patency was a little better than what we saw with the PTA alone, but the 12-month cumulative patency is again very marginal. Some of those patients are only 1 in 3 of those patients who had a bare metal stent were still functional at the time, at about 1 year after the procedure. So we cannot say that this is the ideal treatment for these patients. So we kept looking, and now the debate is There was this study from Turkey that looked at stenting versus PTA, and perhaps it's also pointing out the fact that there are these elastic lesions versus the non-elastic lesions. And what they found was completely opposite of what we've been trying to show, that the stents may be better. The stent group actually had more interventions compared to the angioplasty group. And then the primary patency also was better in the angioplasty group. So perhaps if those lesions are different, and there are different pathologies that we are dealing with, and if it's a fibrotic lesion which tends to open up, may be different than probably an external compression or a more elastic lesion which tends to collapse back despite repeated procedures in these patients. The PTFE covered stents have had just recently been used, and the experience is really small with these, and there are only a handful of studies with small number of patients. This is a study with about 42 patients using one of the Gore wire band covered stent. The primary patency and the primary assisted patency is a lot better with the covered stent. So perhaps there is a signal here that if you have a patient which has a primary PTA and if it fails and there is a recoil of more than 50%, or there is a recurrence of stenosis within a short period of time, the next procedure should be an angioplasty with a covered stent. So I just want to highlight the difficulty that we face in these patients with just one case that we've seen recently. It's a 70-year-old female who's had multiple PTAs at outside facilities and then at our facility as well, had a bare metal stent placed at one of the outer facilities and was sent back to our facility because she had arm swelling again. She had multiple collaterals on her chest wall, and when you do a fistulagram, you can appreciate that the wall stent has extruded out, and this is because the wall stents tend to have a memory and they do not really conform to angle. So putting them at an angle is always a problem. So how do we fix this patient? So you need to know a better anatomy of that patient and see where the catheter is, or where that stent is. And it seems like it is extruded out, but there is no extravasation, so it's probably formed a little fibrous tissue covering the stent all along. So if you're able to get a 014 wire that we change over to an 035 wire through the wall stent and then dilated the wall stent to place another wall graft stent within that old stent, and that took care of the problem. It just highlights that these patients will require multiple procedures and multiple interventions to maintain these access. So poor outcomes, multiple procedures, and it all comes at a very high cost, not only medically but also financially for the patient. So I would recommend that the central vein preservation is the key. We need to focus on it in our daily practice. And for a CKD patient, a team approach is the best way to move forward. The nephrologists have to engage the interventional nephrologists and the surgeons and the primary cares and the internists. We need to have some policies in place in the hospital, and the nurses need to be educated about what we need to do and take care of those CKD patients. The one person which is not included in this list is the patient, and I think we need to try and get the patients on board and educating them about the outcomes associated with central vein thrombosis and the risk of recurrent infections and morbidity associated with starting dialysis with a tunnel dialysis catheter. The mortality in the first year is certainly way higher if you initiate with a tunnel dialysis catheter, and there is no other therapy that I can provide to my patient which will decrease the mortality versus only if I would start that patient with a fistula rather than a graft. We've talked about subclavian, which should never be used in a patient with CKD. I mentioned PICC line earlier, is a higher risk of thrombosis. Instead of PICC line, we have a policy of placing a single lumen cuffed Hickman catheter in the IJ, which we remove promptly. We have a hospital policy, so any patient with CKD, a GFR of less than 60, which needs a central venous line, and PICC line team is well aware of that, and they would call us and ask for any alternative options. And then as soon as the catheters have served their purpose, they need to be removed. Cardiac rhythm devices, are always a problem, and they have a very high risk of central vein stenosis. There are epicardial cardiac rhythm devices available, and they should be preferred in CKD patients. There is some studies which suggest that the stiff short catheters, the short-term catheters, dialysis catheters which are stiffer versus the soft-tipped catheters may have a higher risk of stenosis. Perhaps we can start AKI patients, which we know are going to be on dialysis for at least 4 weeks or more with a tunnel dialysis catheter, and certainly avoid putting short-term catheters on the left internal jugular vein. We need to think outside the box. If the patients do not have a functioning AV access at the time of initiation of dialysis, there are other options. Certainly peritoneal dialysis is something which is widely used and available in this part of the world, should be offered in all of these patients. We've had for the last several years a program which we call the Urgent Start Peritoneal Dialysis Program, where the incident acute ESRD patients who do not have any prior CKD care and do not have a functional AV access get PD catheter placed by the nephrologist and then start low volume supine exchanges within the first day of placement of the PD catheter. So now you've established a PD catheter in that patient and prevented the risk of tunnel dialysis and the associated morbidity with that. There are rapid cannulation AV grafts that we have used for patients who do not have an AV access. And these are flexine and grafts that can be cannulated within hours of placement so that you can start dialyzing them through a graft, an AV access, rather than through a tunnel dialysis catheter. So in summary, central vein is an integral part of dialysis vascular access circuit. Early access planning is vital in preventing loss of central vein patency. And stenosed central veins may require multiple interventions which do not have very good outcomes. And preservation does require teamwork and patient participation to achieve success. Thank you.
It's over to the chairperson.
The talk is now open for questions from the house. Can I ask, this is very naive question, why this central venous stenosis occurs more with subclavian rather than internal jugular? Is it something to do with the anatomy of the vein, or are there other factors which are involved?
I think one of the factors that's been associated with higher risk of stenosis is wall contact. When you puncture the subclavian vein, the catheters tend to sit on the posterior wall or the lower wall of the subclavian and then go down into the right IJ. Whereas if you puncture the right IJ, the catheters tend to fall straight down and they have less wall contact. The higher the wall contact, the higher the risk of stenosis. And also, the puncture site is always prone to thrombosis. So frequently we find our CKD ESRD patients which have right IJ veins that are thrombosed and they are gone, because that's where the puncture is. So if you puncture the subclavian, that's where the thrombosis is going to be, and more than likely a thrombus and occlusion of that vein will occur.
Okay. Dr. R. Keshav.
Yeah, I agree with you. The only way you can preserve and avoid central venous stenosis is not to use tunnel catheters.
Right.
Because I'll give you our experience. When we were being trained, nobody was putting central lines. The patients were dialyzed by either a PD. PD used to run 24 hours. And the other thing was femoral cannulation, which was done in and out. It used to be painful for the patients, but we never saw such severe problems after the fistula was made. That's what Dr. Rana was alluding to, because if you don't have central venous stenosis, you can be very comfortable in making fistulae, and these problems will not occur. So I would think that peritoneal dialysis, which is almost going out even in the Indian setting, should be encouraged, and the nephrologist, for these patients who need urgent dialysis and don't have access, as far as possible, even for acute kidney injury, should avoid putting central catheters, and rather than start them on PD and make vascular accesses. We have an excellent situation where nephrologists, they can put PD catheters, they can make fistulae. They are not dependent on anybody, which is not there in US. So I think that is the model which is best suited for India.
I'm sorry for the interruption, Mr. Chairman. We have totally run out of time for the discussions of the papers. We'd like to thank our chairpersons and Dr. Sachdeva and other speakers in this session.